Good morning. It's my pleasure to participate in today's Congress to give a brief presentation about MRI of the hip prosthesis. Total hip arthroplasty is one of the most common and successful procedures performed as a treatment for osteoarthritis, and around 5% of these total hip replacement will undergo revision due to various complications. These complications may occur as a result of adverse events at the time of surgery or in the post-operative period. Total hip arthroplasty involves either total replacement of the femoral head and neck as acetabulum by separate prosthesis, or resurfacing arthroplasty with resurfacing of the acetabular and femoral articular surface with metal cups. The type of replacement is further classified according to the material of the prosthesis: metal versus ceramic, articulating surfaces, metal on polyethylene versus metal on metal, or ceramic on polyethylene, and the technique used: cement for fixation, cement or cementless. The post-hip arthroplasty complications include many complications: particle disease, aseptic loosening, infection, periprosthetic fractures and stress reaction, joint instability and dislocation, hardware failure, heterotopic ossification, hematoma, metallosis, and muscle and tendon disorders, either tendinopathy or tears. Let's agree that the plain X-ray are considered the initial step and the initial imaging modality to evaluate the majority of complications. However, it have an important limitation is the lower sensitivity compared to MRI for visualization of the soft tissue structures. MRI provide a sensitive means to evaluate the presence of complications in cases where a plain X-ray is normal or reveals subtle findings, and is the most appropriate imaging modality to use following a radiograph whenever the clinician is suspecting a soft tissue abnormality. Particle disease, aseptic loosening, infection, hematoma, and muscle and tendon disorders are the most important complications that are sought by MRI. What about the challenges we meet in MRI of the hips? The metal components of the hip arthroplasty degrade the image quality because of the magnetic susceptibility artifact, which distorts the regional magnetic fields, creating large areas of signal voids surrounded by streaks of hyper-intense signal. And the degree of this artifact is influenced by many factors. The strength of the magnetic field: the stronger the magnetic field, the higher the artifact. That's why it's one of the few indications where 1.5 Tesla magnets are preferred over the 3 Tesla magnets. The shape of the implant and the composition of the implant. Titanium is less ferromagnetic than cobalt chrome and results in less artifact, as we see in this image where the femoral head made up of cobalt chrome is exerting much susceptibility artifact and much blooming compared to the femoral stem composed of titanium. The metal artifact reduction sequence MRI, this is an umbrella term to describe concepts of metal artifact minimization without compromising the image quality. MAVRIC, which stands for Multi-Acquisition Variable Resonance Image Combination, and CMAC, which stands for Section Encoding for Metal Artifact Correction, are the two most widely used techniques with equal efficacy. These are fast spin echo-based sequences that help to minimize the artifact. These artifact reduction techniques only have the disadvantage of being of longer scan time, so they are not suitable for less cooperative patients than the elderly. Additional effective modifications includes aligning the long axis of the metal components parallel to the axis of the frequency encoding gradient, and avoidance of spectral fat saturation or gradient echo techniques, because these sequences are known to be much degraded by the susceptibility artifacts. And the use of 1.5 Tesla instead of 3 Tesla magnets, as I mentioned. I will start by one important complication, which is the particle disease and osteolysis. The majority of complications related to failure of total hip arthroplasty are thought related to particle disease. What's particle disease? This refers to the reaction that occurs in the response to small particles of debris that are released due to wear of arthroplasty components. This reaction can occur due to particles of metal, polyethylene, and cement. The presence of these microscopic particles within the joint induce a cellular response primarily from macrophages. The inflammatory cells infiltrate the synovium, results in synovitis and effusion, and the macrophages, which are unable to digest the particles, are going to release a lot of inflammatory cytokines and growth factors, provoking bone resorption by osteoclides, causing the osteolysis. These reactions can subsequently cause destruction of the joint and the surrounding soft tissues. That's why the early diagnosis is very important to allow for the timely revision surgery. The earliest MRI finding in particle disease will include the presence of joint effusion, and synovitis, and intra-articular hypointense areas representing metal debris may be found. Osteolysis, this is one manifestation of particle disease and the most important and serious complication that affect the long-term viability of total hip arthroplasty. Bone resorption that occur in osteolysis may be visible on plain X-ray, but plain X-ray are less sensitive than MRI, and the sensitivity of plain X-ray will depend on the location and the size of the lesion. So MRI with proper metal artifact reduction technique have been found to be the most sensitive to detect osteolysis. By MRI, osteolysis can affect any area along the effective joint space from the acetabulum to the tip of the prosthesis. And osteolysis will present as intraosseous masses of intermediate signal intensity, meaning that they have signal intensities that are iso or slightly hyperintense to the adjacent skeletal muscles, replacing the normal fatty marrow. And the characteristic hypointense reem surrounding the lesion, this is characteristic to differentiate osteolysis from other conditions like infection and malignancy. Other differentiating point is the signal intensity. This intermediate signal intensity is unlikely with the malignancy or the infection. They are common to have hyperintense signal instead of this intermediate signal. Osteolysis may result in cortical disruption and a consequent extra-osseous component which have the same signal intensity as the osseous lesion, slightly hyperintense to the skeletal muscle in T1 and T2 with the characteristic hypointense outlines. And these extra-osseous components can compress adjacent structures with special importance on the neural structure, like this case presenting with foot drop. This is a case from the literature. It's not my case, of course, but this was a case of a 67 years old male presenting by foot drop due to compression of the sciatic nerve by this extra-osseous component of the osteolysis. Another example demonstrating the signal intensity of the bony lesion and the extra-osseous component, the intermediate signal intensity with the characteristic hypointense reem. Sometimes by plain X-ray, osteolysis may be mistaken as malignancy, and the MRI is a problem-solving tool by demonstrating the characteristic signal intensity and the hypointense reem, which are unlikely in malignant lesions. Pseudotumors, these are additional manifestations of particle disease, and these are reactive masses that are labeled histologically as septic lymphocyte-dominated vascular associated lesions. The proposed pathophysiology behind formation of these masses is delayed hypersensitivity reaction or direct toxic effect of the metal ions. These are major cause of revision, which required in patients with major symptoms or large lesions, and correct management of the patients with smaller lesions is controversial because it's not known whether these lesions are likely to progress. The MRI appearance of the pseudotumors is variable from cystic lesions, thin-walled cystic lesions, contiguous with the joint space, and metal debris, hypointense metal debris can be identified within these cyclic lesions. Or we have another different appearance with mass-like lesions showing intermediate signal in T1 and T2 with internal hypointense areas representing the metal debris. The periprosthetic or pseudotumors or reactive masses are classified into 3 types based on the MRI. The type 1, which are cystic masses having thin wall less than 3 mm. Type 2, these are cystic masses with thicker wall exceeding 3 mm but less than the diameter of the cystic component. And type 3, which are predominantly solid masses. Pseudotumors can most commonly affect the posterolateral aspect of the joint space adjacent to the greater trochanter, or may occur anteriorly along the iliopsoas bursa. The important point is they show continuity with the joint capsule through the iliopsoas bursa or through posterior capsular defects caused by the previous surgical approach for placement of the prosthesis. Another complication is the aseptic loosening, which is the most significant long-term complication following total hip replacement. Aseptic loosening is described as loss of fixation of the implant as a result of inadequate initial fixation, mechanical loss over time, or biologic loss of fixation caused by the particle-induced osteolysis. Radiographically, the aseptic loosening is defined by the presence of linear lucency along the bone metal interface. By MRI, this lucency reveals to be of fluid signal, linear fluid signal along the bone metal interface exceeding 2 mm in thickness with absence of bone marrow edema. This is suggestive of aseptic loosening. If the bone marrow edema is extensive, of course we will think of infection as a cause of the loosening. But we should be cautious in non-cemented hip arthroplasty, where this lucent zone, but not exceeding 2 mm, may be a normal appearance of the normal fixation process of the prosthesis by fibrous ingrowth. And MRI here may solve the problem by the signal intensity, the hypo-intense signal in case of fibrous ingrowth versus the high signal soft tissue within the lucent zone in case of loosening. But of course, stability over time on serial follow-up will still remain the most important factor differentiating between the two possibilities if MRI didn't find the final solution. Infection, this is the third commonest region for revision. Infection and osteolysis may have confusing radiographic appearance, but on MRI we have suggestive signs that favor infection. The presence of a more extensive bone marrow edema is in favor of infection. The presence of large periarticular loculated fluid collections or abscesses, and of course the presence of enlarged lymphadenopathy adds a level of confidence. The differentiation is important between the infection and osteolysis because the management will be different. In cases of large particle disease and loosening, this requires immediate revision. Small particle disease may be treated conservatively, and of course infection we need antibiotic and another type of therapy. The other dilemma is differentiating the pseudotumors from the infection. MRI is used for such purpose, and infected fluid collections tend to be less defined and lacking the low signal intensity Reem of the pseudotumors. And the soft tissue edema in cases of infection is more extensive and more infiltrating the tissue planes. But finally, if the dilemma is still present in distinguishing the juxta-articular abscess from the reactive masses or the pseudotumors, we can achieve the final diagnostic evidence by aspiration and analysis of the material. Greater trochanteric bursitis can present as a pain over the lateral aspect of the hip, and as it was already discussed at the first lecture by Professor Nahal, that trochanteric pain syndrome, it's not just trochanteric bursitis, it may be caused by presence of gluteal tendinopathy or tendon tears. Metal artifact reduction sequences MRI are the preferred imaging modality to detect these greater trochanteric bursitis, and we should be carefully inspecting whether this fluid collection over the greater trochanter is communicating with the joint capsule or not, to differentiate the pseudotumor from the greater trochanteric bursa in cases of hip prosthesis. The muscle tear, gluteal tendon avulsion is a known cause of trochanteric pain syndrome in patients with hip arthroplasty. Fluid collections tends to be ill-defined and pure fluid and lacking the hypo-intense signal of the pseudotumors, and their typical location at the site of the tendon avulsion, of course, is diagnostic and make the diagnosis more confident. Muscle atrophy, atrophy of the periarticular muscles, which manifest as loss of volume and fatty replacement, commonly involving the piriformis, the gluteus, and the iliopsoas muscles. So to summarize, with the ever-increasing number of hip replacements worldwide, the demand for prompt and early diagnosis of post-arthroplastic complications has increased. Plain radiography should always be the initial investigation, and this modality will be able to diagnose the majority of complications. Radiographs have vast limitations, especially with respect to the evaluation of the soft tissue details, which account for the symptoms in a significant number of patients. With proper adjustment of imaging technique using the metal artifact reduction MRI, conventional MRI scanner are able to provide highly diagnostic imaging for patients with hip arthroplasty. MRI is the most important modality to use following a radiograph whenever the clinician is suspecting a soft tissue abnormality. And metal artifact reduction sequence is proving to be of immense help in detailed evaluation of these soft tissue complications. These are my references for further reading, and thank you for your attention.